She performed her residency training in the USA, and already she is attending in Athens, in Greece, and also in the US in Vasco Palmer Institute. And for us, it's a great honor that you joining us. And this, you are talking about cataract surgery in keratoconus patient. Thank you so much.
Thank you. Thank you so much for having me. It's a pleasure to be here with you today. Let me just share my screen. Let's just do that to make sure it's working. Okay. All right, so I'll be talking about cataract surgery in keratoconus and forme fruste keratoconus. Here are my disclosures, which are not relevant to the content of this presentation. So we should start with some definitions. First of all, let me remind you that keratoconus is a non-inflammatory thinning of the corneal stroma that leads to progressive myopia and irregular astigmatism. And the characteristic of keratoconus is that the point of maximum curvature, or Kmax, is at the thinnest point of the cornea. So if you look at the maps that you can see here, the point of maximum curvature is right here on the anterior curvature map, and it corresponds to the thinnest point on the biochemistry map. So this is characteristic of keratoconus. Forme fruste keratoconus, oops, I think it just froze. I'll have to share again. I'm sorry about that. Let's see. Let's try again. Okay, so now we can go on. And forme fruste keratoconus is a subclinical stage of keratoconus where you only see mild topographic abnormalities. And these abnormalities are often asymmetric or unilateral. So on the bottom here, you see the eyes of the same patient, and the right eye clearly has keratoconus and actually advanced keratoconus with a Kmax about 70 diopters. But the left eye of the same patient has only mild topographic changes. This eye, we will say that it has subclinical keratoconus because we know that keratoconus is a bilateral disease. It's just that the left eye hasn't manifested the disease yet. So when we talk about keratoconus, usually we tend to focus on early diagnosing this condition, on how it progresses, how we define progression, and how we can stop it from progressing using cornea cross-linking. Now, we shouldn't forget that these patients will eventually age and they will develop cataracts, and we need to know how to tackle those cataracts. So the talk is going to have 4 parts today. At first, we're going to have some general considerations, and in particular, we're going to talk about when an aging patient with keratoconus comes to your office, you have to differentiate, is it the cornea or is it the lens, the cataract, responsible for the visual decline, and how do you do that? Secondly, we're going to talk about IOL power selection and what formula to use in this eyes to calculate the power of the lens you're going to implant. Third, we're going to talk about astigmatism management, and in particular, when it is appropriate and when it is not appropriate to implant a toric lens in a keratoconus patient. And finally, we will end with some surgical tips, and in particular, when to combine a cataract surgery in this case, in these patients with a corneal procedure, such as a deep anterior lamellar keratoplasty or a penetrating keratoplasty. So let's start with the first question. Is it the cornea or is it the lens that is responsible for the visual decline? So you should be thinking that the reason that the patient says that his vision is not as optimal as it used to be, you should be thinking cataract. If you have documentation of stable stereotopographies over the years, or if you don't have access to topography, that you see a change in the manifest refraction of the patient, his glasses prescription, with stable keratometry readings. And if you're not sure because you haven't been following the patient, and it's the first time you see them, whether it's the cataract or the lens, and the patient doesn't bring any records with him, the last thing you can do is to use a rigid gas permeable lens over refraction. So if you don't see an improvement with an RGP refraction, that means that it's definitely the cataract what is causing the visual decline. On the other hand, if you use rigid gas permeable lens refraction and you do see a significant improvement, then you have to think that it is the cornea. Now, we know that in keratoconus, the cornea stops progressing, the cone stops progressing at about age 35 to 40, but still, there are some rare patients that will progress even later on in life. If you see progression in serial topographies over the years, then again, that's another indication that you should be thinking into the cornea and not the cataract causing the visual decline. And the same holds true for the manifest refraction if it's changing, and you see changing keratometry readings as well. Now, there are some cases where it's both the cataract and it's both the lens and the cornea that is causing the visual decline. For example, if someone has had a bad eye drops and they have a lot of apical scarring, it could be that it's both the cornea that is causing the visual decline and also the cataract that you're seeing on exam. And in those cases, you have to address both things to restore the vision of your patient. So, okay, you've decided that it's the cataract and you're going to proceed with cataract surgery. You have to think about what formula you're going to use and what power and what IOL power you're going to use. So we know that in order to select the power of the intraocular lens we're going to implant in any patient, we need keratometry readings, we need an axial length reading, we need an appropriate formula, and we need a refractive target. So let's go through these 4 steps for our keratoconus patients. So in terms of keratometry readings, what value should we use to plug into our formula in order to calculate the lens power? We do know that the more advanced the cone is, especially if the Kmax is greater than 55 diopters, that no matter what device we use, we're going to have very variable measurements, no matter if we use any topographer or optical biometer. We know that both topographers and optical biometry systems, they tend to overestimate the K values. What does this mean? That if we use those K values, we're going to end up with a hyperopic surprise. We're going to choose a lens of less power that the patient needs, so he's going to end up hyperopic. This is not good, especially for keratoconus patients, because they've been used to be myopic all their life. The graph that you see on your right is from a paper that was published in the American Journal of Ophthalmology in 2020, where the authors used different systems to see what K readings are more appropriate for these patients. And it looks like shine film systems, such as the Pentacam, that they tend to be more accurate than placido topographers or optical biometers. So in this case, the graph here shows that the Pentacam measured a lower corneal power in about 3/4 of the eyes that were examined in the study by about 0.37 diopters, compared to optical biometers, which were the IOL Master 500 and 700 and the Lenstar that was used. So in more advanced cones now, if you have a very advanced cones, then it may be prudent instead of just using the general K values that the Pentacam gives you, to use the central 3mm keratometry values. And how do you find those on the Pentacam? Well, you have to look at the Holiday EKR detail report. This is the second screen that you see here on the bottom. And let's take a look at it in more detail. So this is the Holiday report that is included on the Pentacam software. And if you can see here on top, you can see the K1 and K2 values at 1mm, 2mm, 3mm circles from the apex of the cornea. So you can use the 3mm ones, and you should be getting a more accurate estimate of your K values. So you can use these values to plug into the formula that you're going to use to select your IOL power. Okay, so for keratometry, we said we need Ks from shine film tomography, and for advanced cones, we should be using Ks from shine film tomography from the central 3mm values. Now, for axial length, we're going to use a biometry system like the IOL Master, the Argos, the Lenstar. What we need to know for these patients is that they're going to have fixation issues. So don't take only one measurement, but rather take several measurements to make sure that you have the right axial length. Now let's move on to the more interesting question. What is the IOL power calculation formula that we're going to use? This is the same paper I showed you before from 2020, AJO. And in this case, the authors examined several of the most common formulas at that time, such as the Hoffer Q, the SRKT, Holiday 1, the Haggis, the Barrett, and the Holiday 2. And as you know, and they also divided the eyes that they examined into 3 stages. So you have stage 1 keratoconus here with a Kmax less than 48 diopters, stage 2 from 48 diopters to 53, and stage 3 greater than 53 diopters. And the values that you see here on the table is so all the values are positive, meaning that all the formulas result in a positive predicted error, which means that you're going to have a hyperopic error if you use those formulas. And as you can see, the more advanced the stage of disease is, the more significant the error is. So for stage 1 disease, you have an error of up to 0.6 diopters from all the formulas here, stage 2 up to 1.5 diopters, and in stage 3 up to 4.5 diopters. So you could be 4.5 diopters off if you use, let's say, the Holiday 2 formula that you see here for stage 3 cone. So you have to be aware of these errors, where your patient is, and you can adjust your refractive target accordingly. But instead of like spending more time with these formulas, which were the basic formulas we had, over the since 2020, we also have keratoconus specific formulas. And this is a more recently published study in JCRS 2023, where the authors are not only looking at the standard Barrett universal formula, but they're also looking at the Barrett True K keratoconus formula. And they're using both the Kane formula, the general Kane formula, and also the Kane keratoconus formula. Again, as you can see, they have divided the eyes to the 3 stages of disease in keratoconus. And as you can see, all the values are positive, or almost all. So you have a positive error again, so a tendency towards hyperopia. And the more advanced the cone is, the higher the numbers are on these columns over here. But if you compare the regular formula with the keratoconus specific formula for the Barrett, you see, for example, for stage 1, that the error would be plus 0.4 diopters. But if you use the Barrett True K keratoconus specific formula, the error is half as that, is about 0.2. And especially for stage 3 eyes, you see that you have a significant difference, 1.76 to 0.5, very big difference. The same holds true for the Kane formula and the Kane keratoconus formula. Let's say for stage 3 eyes, almost 2 diopters of error with the regular formula, with the keratoconus specific formula, half as that. So for these patients, if you're not already using these formulas, you're doing a disservice to your patient. Both the Barrett True K keratoconus formula and the Kane keratoconus formulas, they're online and they're free to use. And here you can see the websites for those formulas. And you just plug in the numbers. We said you plug in the case from your Scheinflum system or the 3mm case from the Scheinflum Pentacam system. You plug in your axial length that you've taken a few measurements to make sure you don't have fixation issues from whichever diameter you have. And then you use these formulas to calculate the IOL power. The last thing you need is the refractive target. So because we said that all formulas, even the keratoconus specific ones, as you saw in the previous table, they tend to have a positive error over here. You have to adjust a little bit your refractive target to account for that error. So you always counsel the patient that, I'm going to aim for the best, but sometimes we cannot be as accurate in your case because you have keratoconus and our machines are not as good in measuring the specifics we need to calculate the IOL power correctly. So in all my keratoconus patients, I target myopia. And depending on the severity of the cone, I will target from -1 to -2.5. And I tell the patient that, you may end up a little bit myopic, which is usable vision for you, and you've been used to be myopic your whole life. Or at best, you will end up emmetropic, but at least we're going to do the best to avoid hyperopia, which is vision that is not very usable. Okay. And then let's talk now about when to correct astigmatism in these cases with a toric lens, because not all keratoconic patients are good candidates for a toric lens. So these are the questions you have to ask yourself when you see a patient with keratoconus and you're considering toric IOL implantation. First, the age of the patient. Then, is the cone stable? The third question, do you see a visible axis on corneal topography? And this is the axis that you're going to use to implant your lens on. Or is the astigmatism that you see very asymmetric? And the last question, does the patient correct with spectacles? So if you give them glasses and you put the astigmatism on their glasses, even if they don't tolerate the prescription, just as a test in your exam room, does the patient correct with spectacles, or does he or she need a rigid gas permeable or a scleral lens? So let's talk about this in more detail. How old is the patient? So the older the patient is, as we said before, the less likely he or she will progress. So this is a good thing to know. Is the cone stable? You want to have documented topographic stability for at least 1 year or more. So that you can select the appropriate toric lens, and then you won't have changes in your refraction after that. Is there a visible axis? You need a clear axis on your topography, and that's the axis where you're going to implant your toric lens at. And then if you know that your patient is already using a scleral lens or a rigid gas permeable lens preoperatively, probably they're not good candidates for toric IOL placement. Probably their astigmatism is too asymmetric for a toric lens. And you should let them know that they will need to use lenses like an RGP or a scleral lens, which will be different than what they were using before, but they will still need to use them after cataract surgery. So let's take a look at these topographies. Would you recommend a toric lens for the following patients? They're all of them are old enough and they are topographically stable for at least 1 year. So you know this and you see this three topographies. So the one you see on the left, yes, it is keratoconus. There's clearly a symmetric astigmatism, but you have a visible axis, okay? So if this patient also corrects in his glasses in this axis, then yes, this is a good patient to implant the toric lens. In the middle case, you don't really see an axis, okay? This is an advanced cone, and you see this big red blob in the bottom, but there's no visible axis. There's no bow tie configuration that you can discern here. So this is not an appropriate candidate for a toric lens. And in the last case, well, let's see, maybe you have an axis there, maybe not. So if your patient refracts on that axis and the vision improves on that axis with glasses, then yes, you could try a toric lens. But if not, then you shouldn't be trying a toric lens and you should just go with a monofocal lens. To make these points more clear, let's look at a case. So this is a 63-year-old priest, and he has blurry vision in both eyes, more the right than the left. He also has more advanced keratoconus on the right eye. And although he's using glasses for the last few years, he used to use RGP contact lenses in the past. He just got tired of them, and that's why he stopped using them. He also has a non-proliferative diabetic retinopathy with no evidence of macular edema. His best corrected visual acuity with his glasses is 2100 in the right eye, and you see he has 2.5 diopters of cylinder in his prescription. And in the left eye, 2080 plus with about 2.25 diopters of cylinder. His pressures are normal. His cornea is clear. There's no apical scarring in the cornea to justify why his vision is down. And you can see on exam that he has nuclear sclerotic cataracts in both eyes. So you're going to recommend cataract surgery. And you do your biometry. This is the IOLMaster 700. And as you can see, you see the K values over there for the right eye, which is more advanced, and the left eye. And you have your astigmatism here over here. So the IOLMaster and all the optical diometers will try to give you K values regardless if there's a visible axis on topography. So the question is, can you just rely on these measurements and go ahead and order your toric lenses? Well, the answer is no. As we said, you need to look at the topography here. You need to look and make sure that there is a visible axis. So here's his right eye, and here's his left eye. So if you look at the anterior curvature map in their right eye, you see again that you don't have a visible axis here. You just have a big red blob inferotemporally, but there's no discernible axis. Whereas in the left eye, you kind of see that there is a bow tie configuration here, and you have an axis. So the left eye is a good candidate for a toric lens. So let's take both eyes one at a time just to explain this a little more. So this is the right eye. The K max that the pentacam gives you is 59.9, and the astigmatism that this gives you here is 2.3 at 151 degrees. What he wears as his glasses is 2.5 at 115. So it's different. It's very different from what you see on the pentacam. And this is another reason, like we said, he doesn't refract on that axis, that you shouldn't be using a toric lens. So if you go through the process, how old is the patient? He's old enough, very unlikely to progress. You know that the cone is stable for several years. Do you have a visible axis? No, you don't have a visible axis. Does the patient correct with spectacles? Well, we said that the axis on his spectacles is very different from the topographic axis, and he also tells you that he was getting much better vision when he was wearing his RGP or scleral lenses in the past. So is a toric lens appropriate for his eye? No, your answer should be no, not for the right eye. Let's take a better look now in the left eye. So the left eye, K-max 49, so it's his better seeing eye. The cylinder, the astigmat is 3.3 at 43.4 degrees here. And what he wears in his glasses is very close. He wears 2.25, that's what he tolerates, at 50 degrees. So here you have the two values, the topographic cylinder, the axis of the topographic cylinder and his refraction are very close. So yes, this left eye, we should be considering that a toric lens should be appropriate. So if we go through the steps, it's old enough, the cone is stable, and yes, we do have a visible axis on topography, and yes, this axis is similar to the astigmatism axis on his spectacles. And in this eye, he was not as dependent to an RGP or scleral lens in the past to see well. So his left eye is appropriate for a toric lens. And if you use, this is the Kane formula that I showed you before, the website. So you can select here for the right eye, the blue is non-toric, you can select that, and you can select keratoconus formula, and this is what it gives you. As I said, I always go myopic, so that's why I selected the 13.5. And for the left eye, you select toric and keratoconus on the top, and then you get a T7, as you can see here. And I also went myopic because it's more advanced, so -1, 18.5 diopters. Okay, so now let's talk a little bit about some surgical tips and when to combine cataract surgery in these patients with cornea transplant. So first of all, just in general, before we talk about the combined procedure, when you do cataract surgery in keratoconus patients, if you operate from a temporal position, you probably have to change position because we know that infratemporally is the thinnest area of the cornea. And if you make your wound there and it's a clear cornea wound, it's very likely that you're not going to be able to hydrate the stroma and close the wound. You're definitely going to need a suture. If you want to avoid the suture and you still want to operate infratemporally, then it's better to make a scleral tunnel, so you're most posterior to the cornea, and then you'll be able to close the wound easier. Sometimes in very advanced cones, the whole cornea is very thin in the periphery, so you have to make a scleral tunnel even if you operate superiorly. And in these patients, I have a very low threshold to place a suture in the main wound because I know that their healing response is not the same. And I wait a long time to remove that suture. I wait at least 1 month before removing it. I've been burned with this. I've removed the suture at 1 week and the patient leaked despite the contact lens, and I had to take them back to the OR to place a suture and then remove it much later. So when I place a suture because I have a leaky wound in the OR in a keratoconic patient, I wait at least 1 month before removing it. Now, when to combine the surgeries, cornea transplant and cataract surgery in these patients, we said that sometimes you see significant corneal scarring, like you see on the top picture here, or you have a patient that is unable to wear an RGP or scleral lens because they have a very advanced cone, or they've become intolerant of those lenses. They put the lenses in, they have chronically red eyes and the chronic papillary conjunctivitis from the lens. So in those cases, you should be thinking, okay, I need to do both things. And you have several options. You can do the cataract first, and because you're going to avoid an open sky procedure. And we know that an open sky procedure, like you see here, has a risk of expulsive hemorrhage. So if you want to avoid that, you can do the cataract first, and you have a reasonably good view. And in that case, if you know that you're going to do a transplant afterwards, you should use standard case in order to calculate the IOL power. In my case, I know my transplants end up about 45 diopters, so I will use that. You can use 44, 46, depending on how you put your sutures and you know where your transplants usually end up. Now, if the cataract is not mature yet, you also have the option to perform either a PK or a DALC, ideally a DALC if you can do it first, and then cataract surgery at a later time. because in that case, you can use the topography after the DALC or the PKP, and you have a better K values that you're going to plug into your formula, and you're going to have a much better refractive outcome for your patient once he gets the cataract surgery. But both have pros and cons. So it's something that you need to discuss with each patient and take into consideration what availability of grafts you have. Do you have healthy grafts? And you have grafts available that are fresh, overall fresh, and what's the stage of the cataract? Do you have a mature cataract? Do you have an early cataract? So in summary, generally, we spoke in the beginning, is it the cornea or the lens responsible for the visual decline? And we said that we need to look at serial topographies and or changes in the spectacle refraction that correlate with changes in the K readings or not. And if we have any doubt, we can always use an RGP over refraction to make sure it's the cataract or the cornea. IOL power selection, we said that we really need at this age, time and age, we have to use keratoconus specific formulas than the ones we have today, as is the Barrett True K keratoconus formula and the Kane keratoconus formula. And the case that we're going to plug into those formulas should come from shine film tomography and for advanced code from the 3 mm zone, central zone. For astigmatism management, when to implant the toric lens, you need an older patient, stable topography, a visible axis on topography, and a patient that refracts with glasses on that axis that you see on topography. And for surgery, when to combine cataract surgery with a corneal procedure, well, when you have significant scarring, when a patient is intolerant of the contact lenses, and if combined, you have to use standard case for your IOL calculation. And with that, I would like to thank you for your attention, and I'd be happy to take any questions. Thank you so much.
So, Tidia, really, we deeply appreciate your lecture. Perhaps I would like to make some question about here in Argentina, we have already using Kane formula and Barrett True K. Do you have any toric IOL would you prefer? Clarion? Because of the rotation is my question.
Okay, what type of lens? Yes, I use the Clarion lens. Usually I use the Clarion lens. Yes.
And one of our residents, Dr. Santiago. ¿Alguien quiere hacer una pregunta?
Okay. Hello, do you have any experience using rings, corneal rings before cataract surgery to improve astigmatism before the surgery?
Yes. So if you know it's the cornea, then yes, it's appropriate to also use intracorneal ring segment or Kyers, the new procedure, the allogenic rings, in order to improve. I focused, mostly this talk on if there is a cataract and there is a cone, what happens. But if you know it's the cornea that's causing the issues, then yes, you can go ahead and do ring segments first.
Thank you.
Okay, so thank you so much for joining us this morning in Buenos Aires, afternoon in Athens.
Yes.
Okay.
Thank you for having me. It's been a pleasure.
Thank you so much again. And she also is our visiting professor at Maimonides, Universidad de Maimonides here in Buenos Aires. Thank you so much, Sotilia.
Thank you. Thank you so much. Have a good day. Bye-bye.
Okay, so far. Mi clase. ¿No te la di? A ver si hablo con Fola mientras. Santi, pero. No sé si por ahí arranca Fogla y.
¿Cuál es, profe?
Por ahí voy a hacer que hable él antes. Es un PowerPoint. En los transmitís por pequeños.
Yo hago de grupo soporte. Hi, Rajesh. How you doing?
How are you doing?
Okay.
Yeah.
So we are ready, if you're ready also, to start with your lecture. Okay. As you know, Rajesh Fogla is one of the most important corneal surgeons in the world. She's also a very, very nice person. She's visited professor at Universidad de Maimonides here in Argentina. He published a lot of papers, not only about DMEC, but also about big bubble technique. And that's the reason we invite him to give us a lecture about big bubble technique. Thank you so much for joining us.
Thank you, Pablo. Let me connect my slides.
Yeah. Pero no sé por qué acá no.
Yeah, my slides are visible.
Yeah, it's
Yeah.
perfect. Thank you.
El arranque.
Are you able to see the full screen, or because I get this on the side, which anything I need to adjust from my side, or it's okay?
Yeah, we can see perfectly. Thank you.
Okay. Good morning, everybody. I shall be talking about how to successfully achieve the big bubble in dark surgery. I have no financial interest to disclose. Deep anterior lamellar keratoplasty refers to a surgical technique wherein 80 to 85% of the host stroma is replaced by healthy donor tissue and the healthy host endothelium is retained. So the biggest advantage is there is no risk of endothelial rejection. And the surgery is performed in a closed chamber, so the risks of open globe surgery are also minimized. The common indications for performing DALK is usually ectatic disorders like advanced keratoconus or post-LASIK keratectasia. Sometimes we do it for corneal scars and various stromal dystrophies where the endothelium is healthy. Now, there are two main techniques. One which involves the injection of air or viscoelastic into the deep stroma, resulting in a plane of separation between the deep stroma and the pre-decimates layer. And the second one is a manual decimates, near decimates dissection. Predominantly the Malbrand's peeling technique, where you do a deep trephination peripherally, and then you try to peel off the stroma. And there is another manual technique called the Melis technique, where you do a deep trephination followed by a lamellar dissection close to the decimate. Now, the big bubble technique was described by Mohammed Anwar back in 2002, and this involves placing a 27 gauge needle at about 80 to 90% depth into the deep stroma. And when you inject air, you get the formation of the big bubble, which starts in the center, has a dense white margin, and it expands outwards. Now, originally, we thought that the separation was between the decimates membrane and the corneal stroma, but Harminder Dua showed us that there is a surgical plane of the predecimal layer wherein the separation happens when you inject the air into the deep stroma. Now, the type 1 bubble is a separation between the stroma and the predecimal layer. And this is typically what we see. Starting in the center has a dense white frothy margin and it expands outwards. And you can see that in this donor tissue as well, where this is from the reverse side, saying the same phenomena happening. In contrast, a type 2 bubble is a separation between the predecimal layer and the descemet membrane. That's why it does not have a dense white frothy margin. It has a clear margin. It can start anywhere in the cornea, but predominantly starts in the periphery and then goes across the entire cornea, as you see in this donor cornea. And a type 3 bubble is a mix of type 1 and type 2. That means it starts as a type 1 bubble, and beyond a certain point, it breaks into a type 2. So you get a mixed bubble. That's called the type 3 bubble. Now, when you look at these are all consecutive surgery videos, and if you see that if we choose our patients rightly and we perform the exact technique, the big bubble can be done in a very consistent manner. So how do we achieve this consistently? I think the most important part is your case selection. So you don't go ahead and attempt a big bubble in each and every case. So studies have shown that you should avoid cases of macular corneal dystrophy, because in macular dystrophy you have deposits in the predecimal layer, which makes it brittle. Very advanced keratoconus, extreme thinning, or if there are any scars that involve the predecimal layer or the descemet membrane, in all these scenarios, the predecimal layer is already compromised, it's stretched. So if you stretch it further by air injection and attempting a big bubble, you're likely to have an abnormal outcome. So when you see your patient on slit lamp, look at the extent of pathology, look at the corneal thickness across the cornea, and if there is any scar, try to see how deep the scar is. To assess the regional pachymetry, you can use your tomography or use the anterior segment OCT to look at the thickness all across, and especially at the point if you are planning a 8.5 millimeter trephination, then at the site of trephination, what is the minimum corneal thickness? I find anterior segment OCT of the cornea to be the most important investigation, which helps me decide whether I'm going to do a big bubble or a manual dissection. So if I see those two conditions which are crossed out, where the scar is involving the posterior layer, so these are the cases where I will not attempt a big bubble. In terms of surgical instruments, you do need the trephiners, the pointed dissector, air injection cannula. Let's look at in the videos. Now, the first step is doing a nice deep trephination of going up all the way up to 80–85% depth. How do we achieve this? We can have this guarded depth trephiners, which are like the conventional handheld trefine, but it has a blade that extends only up to a depth of about 300, 350, or 400. These are available from Network Medicals, and this way you can ensure that you just get a partial thickness trephination. But the most common is the use of the Hesburgh-Barron trefine, where each quarter turn cuts a depth of 60 microns. So once you apply it on the cornea and you start rotating, every quarter turn cuts 60 microns. So about 6 or 7 quarter turns is usually sufficient to reach up to the desired depth. You have the newer trefines from Moria, which has a metal ring with numbers written on it. So you can preset the depth on this number, thereby you don't have to remember the number of turns. So once it reaches the desired depth, the movement of the trefine stops, so you don't accidentally go deep and perforate the cornea. If you have access to a femtosecond laser, it's even more precise in terms of shape, size, and the edge configuration. You can do that. And in very large diameter bulk surgery, where you don't have the trefines available beyond 9 millimeter, you can take the help of using a diamond knife to cut along the mark made on the surface. So it's important that you center your trefine properly, because in advanced keratoconus, sometimes application of trefines can be a bit difficult and they can slip while you're applying, so it can make your cut eccentric. I like making 4 marks, 2 vertical, 2 horizontal, shows me the extent of the trephination that I'm supposed to perform. And you will also feel as you're advancing, you retract the trephine before applying. And when you start moving it forward, initially it will be free. And when it touches the cornea, you will start feeling the resistance, and that's your starting point. The advantage is you get a very nice uniform cut all around. The next step I like to do is to do a debulking, which is not necessary. Some people inject air even without debulking. The advantage of debulking is it allows me to place my cannula at a deeper plane because I have already removed 30 to 40% of the anterior stroma. So obviously, if I have to place the cannula, it will go deeper than that. By debulking the cornea, you also reduce the incidence of stromal emphysema. And the third advantage is that once you achieve the big bubble, you're not spending time doing the debulking. You can straight away go ahead and deflate the big bubble. One corollary is that if your apex is very thin, then you don't want to debulk across the entire cornea. Like in the second video that you see, you just do a partial debulking so that you can just avoid going across the tip. When you use a needle, sometimes you may be lucky to get it in a single attempt. Sometimes you require multiple attempts. If your needle is superficial, you tend to get a lot of emphysema. And if you try to go deep, because the tip is very sharp, any movement of the syringe results in the tip perforating into the anterior chamber. So that makes it a little bit difficult in the learning curve when you're trying to learn the big bubble arc using a sharp needle. So to avoid that, a lot of blunt tipped cannulas are available, and they all have a bottom port to ensure that the direction of the air is directed downwards. So after doing the debulking, trephination, debulking, you come to the periphery, and then you create a small track using a pointed dissector. And that's because the cannulas are blunt tipped, so they won't make their way into the stroma. And once you get your cannula into the track, you can move it towards the mid-periphery. I usually try to avoid the center in ectatic disorders because that's the thinnest point. So you can come somewhere in the mid-periphery. And as you inject air, you can get the formation of big bubble. I do a sequential injection of air, which means I initiate the bubble and then I go ahead, release some aqueous to reduce the counter pressure, then expand the bubble. So how do you know that you've reached the ideal plane when you're putting in your cannula? One is that as you advance the cannula, if you're facing too much of resistance, then you know that you're in the anterior stroma. But once you reach the deeper stroma, you'll find that there is a sudden giveaway sensation and the cannula advances with minimal pressure. You can keep your pupil dilated and look at the tip of your cannula as you're advancing it. If you're closer to the decimus, you'll start seeing the wrinkles happening at the tip. You can use a pachymetry guided where you use a diamond knife to make a cut of 85 to 90% and then use the depth of the cut as a starting point to introduce your cannula. If you have intraop OCT, that's something like you can make the track with your pointed dissector and then you can withdraw that, assess the track, and then place your cannula once you're sure that it's a deeper plane. And newer femtosecond laser have integrated OCT whereby you can help create a track using the femtosecond laser where you make the tip within 50 microns of the decimus membrane. Now, when you're injecting air, you feel an initial resistance. There is a sudden giveaway sensation as the bubble starts. And as the bubble expands, because the aqueous has nowhere to get displaced, you start feeling the resistance once again. Now, if you continue enlarging the bubble against the resistance, it may reach a bursting point where you will have a spontaneous break. That's because the aqueous is not getting displaced, so the counter pressure is increasing at the same time as the bubble expands. This was a nice experimental study where they looked at the relationship between intraocular pressure and the diameter of the big bubble. And they found that there is an inverse relationship that when you have higher the pressure, smaller the diameter of the bubble because of the resistance offered by the pressure within the eye, and softer the eye, the larger the bubble you get. So based on that, we published this paper where we do advise sequential injection. So you inject air, get the bubble to form, and then you can do your paracentesis to release aqueous and then expand the bubble. So why not do a paracentesis before you inject the air? That would be the logical question in mind. The aqueous in the anterior chamber acts like damping agent. When you start injecting air and you initiate the bubble, you have some control over the rate at which the bubble expands, and that's the aqueous that prevents the sudden expansion of the bubble. If you were to do a paracentesis and you make the eye soft, when you're injecting air, sometimes the bubble may start and expand very rapidly and reach the bursting point. And also, when you are injecting air, you don't know whether you're going to get a type 1 or a type 2 bubble. A type 2 bubble is a separation between the decimates and the predecimates layer. So if you were to get a type 2 bubble, and you've already created a break at the site of paracentesis, as the bubble expands, once it reaches the paracentesis site, there is a risk for the DM to rip open at that point. But having said that, when we did a survey among the corneal surgeons back in 2021, we found that almost half of them did paracentesis and the rest of the half did not do paracentesis. So I think it's a surgeon choice and your control over the air injection that you perform. But doing a paracentesis sometimes can make it easier to achieve the big bubble because the counter resistance is a little less. To identify the big bubble, you can do the small bubble test where you put a small air bubble in the anterior chamber. If you have the big bubble, the small bubble remains in the periphery. And once you deflate the bubble, the small bubble moves to the center. The other way is if your cornea is very emphysematous and you can't really see the small bubble, you release the aqueous, the peripheral cornea will become soft. And in the center, if you have the big bubble, it will continue to remain firm because of the presence of the big bubble. If you have intraop OCT, you can directly see the big bubble, whether it's there or not. During the deflation of the bubble, you can have perforation as well. So to avoid that, you can put in some cohesive viscoelastic on the surface and pass your knife through the cohesive viscoelastic so that the air, when it leaks out from the bubble, it releases slowly, not in a very quick manner. But prior to that, you can soften the eye by releasing aqueous so the counter pressure is minimized. You can release the speculum a bit as well. And once you have deflated, the next step is to do the residual stroma excision. In the first case, you see that we haven't debulked the cornea completely. So once you have deflated the bubble, you go ahead and do the debulking. And the other video, it's showing you that you're using a blunt tip scissors. I use a corneal scissors where the lower blade is longer than the upper blade. That reduces the risk of catching tissue at the tip. And you can then divide it into 4 segments and then excise the residual stroma. It's important to see to it that in the periphery, there are no fibers adherent between the residual stroma and the predecimates layer. If it is there, you can always release that using a blunt tip dissector, and then you can excise the stroma. You can also, if you have a very tiny opening and you are scared to enlarge it, you can always put in cohesive viscoelastic into the big bubble that you created so that pushes the layer posteriorly, and then you can enlarge the opening and remove the residual stroma. The donor button can be punched out similar to what you do for your penetrating keratoplasty. I like doing it from the epithelial side using the same suction trephine after mounting the tissue on an artificial chamber. In this, the configuration, the side cut, the edge configuration remains the same as what you have used the trephine on the host, so the apposition is better. Usually when you use it on the artificial chamber, the anterior diameter is a little smaller than the posterior diameter because as you cut along the cornea, the tissue splays out. For ectatic disorders, I use the same size donor, but in other indications, it can be 0.25 to 0.5 millimeter large. You can also use gamma irradiated corneal lenticules. These are available from Vision Graft, and these are decellularized tissue. We use them for DALK, and we found that it's a good alternative. The advantage is that these tissues can be kept in room temperature, and they have a shelf life of over 2 years. Suturing, you use a similar suturing technique. It's usually about an 80% depth bite on the donor and a 90-95% depth bite on the host side. I like to keep them a little longer than my penetrating keratoplasty, so about 0.75 on the donor side and a 1 millimeter on the host side. I usually start adjusting my sutures after the first 2 to 4 weeks time, which means that If any suture is excessively tight, I replace them, but I don't remove them. The removal is usually after 3 to 4 months. But in the first, after 2 to 4 weeks, depending on how the astigmatism look, if it is very, if some sutures are very tight, I will replace them so that it has some impact on the wound healing. Because once the wound has healed, then it's very difficult to achieve that kind of uniform healing all across. Post-op, the outcome looks pretty good. The best part is the specular microscopy, which shows you very nice, healthy cell counts. So this is the Zima Z8 femtosecond laser that we acquired. We have it, so you can do a mushroom cut, you can make a lamellar cut, and in real time, when you're applying the handpiece on the eye with the suction in place, you can adjust all these parameters. You can adjust the depth. You can see the pink line shows you the track for the placing the cannula, so you can even adjust that. So it becomes very close to the decimets and you can be successful in getting that. So you will see here, that's the femto cut being done. It's a case of advanced keratoconus. So we remove the anterior lamellae, and now you will see that I'm going with my air injection cannula into the tract that was created by the femtosecond laser. And as I inject air, you get the formation of the type 1 big bubble. So I'm doing the same sequential injection where I release aqueous, and then when I go back and I can enlarge my bubble, and that's showing you the small bubble test where you have the small bubble in the anterior chamber. And as I deflate, the bubble moves back to the center. The rest of the steps are quite similar to what I showed earlier. Here, you just have to be careful about the edge of the cut, the posterior cut, because of the stromal emphysema that you get. Sometimes you may miss out the edge and you can over-excise. So it's always important. You can even use a marking pen and just mark the posterior cut so that you know exactly where you have to excise the residual stroma and not excise it beyond the margin. That's how it looks post-op. You can see very well opposed post and donor. While the sutures are in, the astigmatism is usually quite minimal. Study comparing femtosecond DALK with manual DALK, they found that the risk of intraoperative perforation of the decimets and conversion to penetrating keratoplasty was lower with the femtosecond laser-assisted DALK. The other option is to try and inject viscoelastic, cohesive viscoelastic. You get the viscobubble. For this, you need to keep the eye soft because the viscoelastic is more dense. It does not go through the stroma that easily. So you do a paracentesis, release aqueous, so the counter pressure is minimized, and then you can achieve this big bubble. It's important to understand that you can also get a pseudo viscobubble if your cannula is not at the right plane. If it is little superficial, then in the deeper stroma, you can induce separation of the fibers. But then once you open it up, it will not look, the posterior layer will not look as smooth as what you see when you get the actual viscobubble. Once you get it, you can deflate it and then excise the residual stroma and complete the rest of the surgery. Complications with DALK, one is that you have a failed big bubble. So here you see that I'm attempting multiple times. And maybe this is the third attempt where you're able to inject air and achieve the big bubble, but sometimes that may not happen. If that does not happen, nothing to panic. You can always fall back on your, I call it the lamellar assisted peeling technique, because it's similar to Malbrand's peeling technique, or what is popularized as grip and rip, where you, so I don't like to use forceful pressure. I create the peripheral pocket at the edge of the trephination, which is quite deep. And once the pocket is made and you have cut the stroma at the edge of the trephination, you can then use a tooth forceps and grasp the stroma. And as you try to peel it, you can always assist the peeling by breaking the fibers. At times, when you are deep enough, you can see a spontaneous peeling, as you see in that video. The results are pretty good, and I use it for primarily even for cases with scarring, like post-hydrops or scars involving the deeper layer. What about when you get a type 2 bubble? This nice study looking at 3 groups. When they got the type 2 bubble, in the first group, they attempted to bear the decimets in the type 2 bubble. In the second group, they did not do anything. They just did a near decimets manual dissection. In the third group, They did a near decimus manual dissection and just released air from the type 2 bubble. So I think the first group where they attempted bearing the decimus, majority of them ended up with macroperforation, conversion to PKP, and they put in air bubble. They had a lot of double anterior chamber and urethra. But in the other two techniques, they were all successfully converted to DAO. So I think the best option, if you get a type 2 bubble, is to just do a near decimus manual dissection. And if the type 2 bubble is small, you can leave the air for spontaneous reabsorption. If the type 2 bubble is very large, where the decimus is in contact with the iris and the lens, you can make a small nick just to release the air from the type 2 bubble. You can get a double anterior chamber, especially if you have had any intraperforation or if you're dealing with conditions like macular dystrophy. It can be very easily managed by using air or gas tamponade, but you have to watch out for pupillary block. Intraop, if I know that I've had a perforation, I do a vertical, paracentesis at 6 o'clock, right at the peripheral limbus, and do a small surgical PI, which avoids a pupillary block when I do a complete air fill. Or the other option is you have to keep the pupil dilated and observe the patient 1 to 2 hours post-surgery to make sure the air or gas bubble is clearing the inferior margin of the pupil. You can have perforation like in this. You will see that we had a perforation while trephination. You want to go really deep or you miscalculated and you can go through and through. So no worries. In this scenario, in this case, we put in an air bubble and then we place some sutures at the site of perforation. And you can see that, yeah, and just put in an air bubble now. So the options are you can either you see me that I'm putting in my cannula and I'm going to try and attempt a big bubble starting opposite from the site, or we can do a manual dissection starting from the opposite end. So you can still complete your surgery successfully even if you had a problem like what you saw just now. This is a case where I had a macro rupture when I was demonstrating the surgery, and you can see it's a fairly large rupture extending from one edge of my trephination to the other. You can see that on the intraop OCT as well. So we went ahead and did the dissection up to the type 1 bubble plane that we did, put in my graft, and then I placed an air bubble in the anterior chamber and the edges of the perforation using a reverse Sinski. I just brought the edges together, I opposed them, and this you can see on the anterior segment OCT, intraop OCT images as well, that the edges are well opposed. And after that, I'd done an inferior PI, so I did a complete air fill. And having an intraop OCT is definitely a great advantage because it allows you visualization. So this is the same patient. You can see next day post-op, the no double anterior chamber, the layers are well opposed. And a month later, you can see the cornea is clear. There's a faint scar at the site of the macro rupture. And that's the topography. You can see that the keratometry of 40, 46 looks fairly good. And he achieved almost about 20/40 in 3 months. And now he has finished 2 years. He's almost 20/20. So how about the learning curve? Because if you look at a lot of the single surgeon results, they're pretty good because they're more experienced. They do large volume. But what about doing a large number in a multi-surgeon setting? This nice paper published from Moorfields by Bruce Allen, they looked at multi-surgeon from experience to trainee surgeons doing DALK surgery, 357 eyes, and you can see that almost 77% achieve 20/40 or better. So that itself tells you that you can achieve pretty good outcomes even if you have the setting of variable experience of the operating surgeon. Obviously, when you're starting off, you may have increased risk of perforation, but the chances of you really need not convert to penetrating keratoplasty every time you have a perforation. So that's a flowchart that gives you decision making in DALK. It is basically whatever points I have covered in terms of what you need to examine the patient preoperatively, and depending on the finding, if you're very steep K, thin corneas, or if there is any scars, don't attempt big bubble. Or if you have a normal case, you're using the air injection, and if you get a type 1 bubble, you can continue. But anywhere else, if you get a type 2, type 3, or a microperforation, fall back on manual DALK. So in conclusion, DALK should be considered as the procedure of choice for any corneal disorder where the endothelium is healthy. Surgical techniques continue to evolve, ensuring greater success of big bubble DALK. So it's like these kind of teaching sessions where I try to share my points is an attempt to try and make sure that people are more successful in doing the big bubble DALK. But it's important to understand the pre-op evaluation and surgical planning is essential to minimize the complication. And in future, the femtosecond laser technology like the ZIMA Z8, which allows you to make the edge configuration, make the cut, peripheral cut, do a lamellar cut, and then even create the track for air injection and the help of intra-op OCT. These definitely will make it much more easier and more reproducible and help improve the outcomes in future. This is a textbook that we wrote a chapter. If you have access to that, you can look up all these points, what I discussed just now. And thank you for your patient hearing. That's my YouTube channel. There are a lot of surgical videos on big bubble DALK. Feel free to access that, and I'm sure that will be helpful for you. Thank you.
Dr. Foglia, thank you so much for your great presentation. I'd like to perform just one question. As you know, here it's a public hospital, and we don't have femtosecond. So really, do you think there is any difference between manual technique and femtosecond for some steps of this procedure?
In my practice, I would say over 95% of cases are done with the manual trephination. It's only 5% that we use the femtosecond laser, and that's mainly because of the cost, because not every patient is willing to pay for the added expense. But having said that, the cases where I've used the femtosecond laser, it's a delight to operate because you see the precision of the cut, the way the donor host and the host bed, they kind of match with each other. Even the post-operative outcomes, in the short term, they look great. But if you look at in the long run, I think they are comparable. So I think a good manual big bubble DALK is as effective as doing a femtosecond laser DALK.
Mucho bien. Okay. Dr. Foglia, again, we deeply appreciate your lecture. Again, thank you so much for joining us.
Thank you. Thank you for the opportunity.
Thank you so much. Bye.
Thank you.
Bueno, yo sé que algunos no están en el tema corneal, pero les comento algunas cosas que dijo que son muy, muy importantes y que de hecho no hacemos. Una autoridad mundial en Big Bubble. Una, la diferencia donante-receptor. Lo hace del mismo tamaño. Segundo, la necesidad de hacer grasas. Una paracentesis previo a hacer la burbuja. Que en la Argentina, les digo, Arturo Maldonado Vaz siempre insistió en eso. Fue el titular de Córdoba. Muchas gracias. Sí. Y bueno, y ustedes fíjense que el tener un microscopio con OCT, yo les diría que es hasta tal vez más útil que para la cirugía vitreoretinal. Es una cosa para la córnea, la verdad que, pero bueno, hay un solo microscopio en la Argentina. Bueno, y ahora para terminar este accidentado Ateneo, que dentro de todos zafamos, les quiero hablar un poco de mi acotada experiencia en endoftalmitis post injertos penetrantes, pero cuando uno empieza a mirar la bibliografía, no es tan pequeña mi experiencia. Entonces, les quiero contar. ¿Podría pasar algo con esto? Sí, gracias, Santi. Bueno, lo paso por acá, ¿no? ¿Está prendido? Yo lo... Bueno, lo paso por acá, lo paso por acá. Lo paso por acá. Bueno, ustedes vieron que lo que hacemos hoy, cuando tenemos la desgraciada situación de una endoftalmitis, y de hecho yo vengo de sobrevivir de una las pasadas 2 semanas, uno lo que no tiene que dudar frente a una situación en la cual un paciente tiene ojo rojo o dolor, no es así. Muchas endoftalmitis no tienen ni siquiera ojo rojo. y muchas ni siquiera duele el ojo. Entonces, cuando ustedes ven un posoperatorio que no es el habitual, y ustedes hicieron la faco bien, pero algo no les cierra, acuérdense de mí, nunca duden de tomar una muestra y al menos colocar banco y cesta dentro del ojo. O hay otros antibióticos de los cuales se puede hablar, como el lidesonide. Muchas gracias. Y la verdad es que cuando uno evalúa datos duros por el sistema Cochrane, solamente un paper de más de 600 papers que se estudiaron pasó los controles de Cochrane. O sea, es increíble que uno de los temas más dramáticos a los cuales uno se puede enfrentar como oftalmólogo, que tarde o temprano incluso los jóvenes, un tema estadístico, se van a encontrar en una situación así, y la verdad es que lo que hacemos es lo que este paper de la utilidad de la vitrectomía temprana en endoftalmitis exógenas marcó. Aún así, para los que hacen metodología, la verdad que hay muchísimo sesgo, mucho sesgo. Y sobre todo, el paper lo que planteó es que frente a un paciente con endoftalmitis y que tiene algo de visión, uno tiene que tomar una muestra inmediato que le hacemos de cámara anterior, le hacemos PCR inmediata y se pone a cultivar y hacer una intravítrea, y si a las 24 horas la cosa no cambia, bueno, uno puede discutir si hace una vitrectomía o no. Pero lo que sí no puede hacer es una vitrectomía de inicio porque el ojo está tan inflamado que genera mucha morbilidad. Entonces, el resumen de este paper sigue siendo el gold standard, pese a que tiene 30 años desde su publicación. Y este es un tema de enorme controversia, de enorme controversia. Y de hecho, muchas escuelas lo que plantean, y cuando uno evalúa datos duros, uno tiene que ser muy riguroso en lo que va a decir, pero lo cierto es que cada vez uno tiende más a actuar que a lo meramente observacional. Y muchas endoftalmitis, les cuento, zafaron, incluso que hemos tenido acá, o han sido gérmenes de baja virulencia, no porque hayan sido TAS. Entonces, ustedes saben que definimos a las endoftalmitis como una situación en la cual el paciente tiene el ojo inflamado debido a un agente infeccioso y es una absoluta emergencia. Uno en general los controles suele tenerlos en el consultorio a primera hora y es una decisión dramática el salir corriendo a tomar una muestra y colocar una intravítrea, pero lo cierto es que uno no tiene que engañarse y recordar que no todos los pacientes tienen hipopión, la mayoría cursan sin hipopión, no todos los pacientes tienen ojo rojo, no a todos los pacientes les duele el ojo, no todos los pacientes vienen con edema palpebral. Y la incidencia, gracias al designio divino, es baja para la FACO. Y de hecho el famoso que Pellegrino nos ha educado, Ricardo Weinstein, que es el 0,5%, pero en realidad, si nos sincerásemos, probablemente la incidencia es un poco más alta. Pero es enormemente más alta cuando uno se injerta un uniforme. Es enormemente más alta. Y de hecho, depende de la literatura donde estemos buscando datos, va a cerca del 2%, que les aseguro, eso en medicina es muy alta. Y de nuevo, una cosa que quede claro, frente a la dramática situación de encontrarnos con la sospecha de una endoftalmitis, uno no debe dudar en tomar la muestra para hacer PCR y dejar en cultivo, y de inmediato, el mismo procedimiento, el hacer antibióticos intravítreos, y la realidad es que colocamos también dexametasona intravítrea. La Asociación de Bancos de Ojos de los Estados Unidos planteó que ha habido un incremento de las endoftalmitis post injertos de córnea endoteliales. Y el motivo de esto tal vez sea la manipulación del tejido en los bancos de ojos. Yo personalmente los trasplantes endoteliales que he hecho los últimos 5 años han sido con córneas cortadas en el exterior. ¿Por qué? Porque hemos tenido la dramática situación de cortarlas nosotros y no hemos tenido la calidad de corte que uno desea, o hemos, alguna vez incluso con Argento acá, hemos roto tejido donante, Y en realidad no es lo mismo que uno que puede cortar una córnea X tiempo que un banco de ojos que hace 10 cortes por mañana. Entonces ya la córnea me viene con toda la serología, me viene cortada incluso en algunos bancos con láser de femtosegundos. Pero lo que plantea este paper es, ustedes saben, y se pueden plantear a sus pacientes, que el tejido humano que uno trasplanta no puede estar estéril, porque si no uno mata el tejido biológico, de manera tal que desde hace ya muchos años se usan distintos tipos de sustancias que en los Estados Unidos es básicamente el Optisol, y el paper este plantea el agregar voriconazol. Y hoy los bancos de ojos premium en los Estados Unidos nos ofrecen, si usted quiere, al Optisol agregarle voriconazol. ¿Por qué? Porque se ha visto, y yo ya tuve un caso, estoy mostrando que la córnea donante me vino con una cándida albicans. Y que, bueno, gracias al hacer el diagnóstico rápido y al buen manejo que me ayudó el infectólogo de Alessandro, tuve un muy buen resultado y la paciente tiene muy buena visión. Pero para la cándida albicans, lo que plantean en el Banco de Estados Unidos es que al Optisol agregarle voriconazol. Entonces ahora les quiero mostrar algunas de las experiencias de estos años. Este es un paciente que con el papá de Federico nos rompíamos la cabeza para ver qué tipo de distrofia era. Gustavo tenía una enorme experiencia viendo distrofias y como nosotros hicimos agua, se lo llevamos a Enrique Malbrán, que hoy Fogla lo mencionó, el gran Enrique II Malbrán, y él nos dijo, la verdad es que me parece que es un Reisbachler, pero vamos a ver hematoxilina y eosina. Y la realidad es que uno siempre que saca tejido tiene que ver el correlato con el patólogo, y fue un Reisbachler. El Reisbachler es una distrofia anterior, muy rara en el promedio, un poco más frecuente en el hemisferio norte, un poco más frecuente, y que como todas las distrofias anteriores, recidiva en el tejido donante promedio una década después. Y como ya estoy viejo, este paciente yo le había hecho un injerto hace más de una década, requirió un segundo injerto, después ya cambió el jefe de córnea, aparecieron otros fellows, le habían hecho una trabeculectomía, lo habían operado de catarata, yo perdí el contacto con el paciente, pero en una calurosa mañana de enero, el paciente viene a la consulta con baja visión. Un absceso de córnea. Un absceso de córnea muy serio que tomamos muestras y al día siguiente la situación fue aún más dramática porque empezó con este adelgazamiento, un melting corneal, empezó a derretirse la córnea y le hicimos una ecografía y vimos que el vito estaba tomado, así que tomamos una muestra y se hizo una intravítrea y me quedaba sin cámara y entonces yo hablé con gente amiga, la mayoría estaba veraneando, y entonces yo lo metí en el quirófano eh, y lo que hice fue colocarle los trocas, en ese época usamos más 23G, yo tenía muchas dudas respecto a si tenía que poner un mantenedor de cámara anterior o no, y hablé con varios cirujanos, y la verdad que uno me dice una cosa, otro otra, y cuando uno busca la biografía, la verdad que es un gasto. Entonces, lo que yo hice fue, ustedes saben que tenemos mucha dificultad para conseguir córneas, pero cuando el paciente está infectado, córneas tenemos. Así que le coloqué la córnea y con una cuadra esférica, apoyándola sobre la córnea, en esa época todavía no teníamos el biom, pude ver como lo que vieron ustedes recién. O sea, pude hacer la vitrectomía central, que la realidad dentro del mundo de la cirugía vitroretinal es una cirugía técnicamente fácil. Uno tan solo lo que hace es el comer el vitro central sin hacer daño e irnos. Y acá vemos el postoperatorio inicial con edema en la córnea donante y el paciente evolucionó muy bien. Otro caso, un absceso enorme que genera una endoftalmitis. Y acá le coloco la queratoprótesis de Eckhart. Una queratoprótesis que el doctor Marcelo Sass nos ha enseñado a usar y que en la Argentina la fabrica el doctor Forner. Usted fíjese cómo puedo ver, hago un shading, puedo ver retina periférica perfecto, perfecto. Usé varias queratoprótesis. Y la realidad es que lo ideal es que tenga un borde siliconado, que técnicamente en Argentina no se puede hacer. ¿Por qué? Para lograr más hermeticidad de cómo uno coloca los puntos. Entonces el gran tema, y acá fíjense que yo le hice un redma iatrogénico y le pude hacer láser, pude trabajar perfecto. Entonces, Coloco la queratoprotesis de Eckhart, que actualmente la cruz es una de 175 o una de 8, y luego tenía tejido fresco, coloco la córnea donante. Otra situación que fue dramática, paciente, pues son todos ojos únicos, la mayoría, con una queratoprótesis de Boston, ojo único, entonces coloco la infusión y con el trocar trato de ver, no se veía nada, pero la realidad es que a medida que uno va haciendo la vitrectomía y por dinámica del fluido se va moviendo la secreción, la realidad es que se pudo ver muy bien para hacer una vitrectomía, una cornea básica y colocar antibióticos, y el paciente aún hoy está con visión. Es decir, no confundir una queratoprótesis de Boston, que es permanente, con la queratoprótesis transitoria, que me permite resolver temas cuando el segmento anterior y posterior están comprometidos. Este es otro paciente que fue reciente el caso. Fíjense cómo está comprometida toda la córnea donante y fíjense, coloco el trocar y miren lo que pasa. Explotó. Entonces, uno aprende mucho también de sus errores. Yo ahí aprendí, primero, fue lo que con la anestesia general, casi mi infarto, saqué el tejido como pude, todo para mandarlo a cultivo y al patólogo. Lo que hice acá fue poner la córnea. Este es un paciente que la sesión que ustedes vieron y que requirió 2 injertos, que yo no los hice. Todo fue porque pasó caminando a algún lugar donde estaban cortando una planta y su infección fúngica. Estaban podando una línea mar del Plata. Bueno, y acá se usa un mantenedor de cámara. Nosotros usamos mucho el mantenedor de cámara anterior, pero la realidad, excepto para los campeonatos en inglés, es algo cuesta $3. Y acá sí, con el mantenedor, yo la idea de colocar un trocar, siempre con muy baja infusión, y bueno, hacer las ciegas una vitrectomía central y colocar antibióticos. Y este paciente evolucionó bien. Otro paciente que fue reciente, y fíjense, tenía un punto flojo que dio inicio al acceso, así que cambio el punto, coloco los trocars, siempre de difusión muy baja, y fíjense cómo tuve que sacar membranas de cámara anterior, y pese a que al principio no se veía tan bien el fondo del ojo, la verdad es que fue mejorando la situación y con muy buena evolución. Entonces, cuando ustedes vayan a hacer una vitrectomía en un paciente que tiene un injerto de córnea y que está usando endoftalmitis, tienen que usar sí o sí lo que en la Argentina llaman anillos de fibra, anillos de infusión. Y tienen que colocarlo de manera tal que cuando emplacen los trócares no estén incómodos. Por supuesto, uno coloca, como siempre, primero el trócar de infusión, y la vía tiene que estar con una infusión muy baja, y con el Constellation uno se lo puede controlar bien. Uno quita la córnea y en función de la situación tiene que resolver la infección. Entonces uno va a utilizar una queratoprótesis transitoria, o bueno, en algunos casos, como hemos hecho, directamente la córnea fresca. Y a veces nos ha pasado de hacer la vitrectomía y volver a colocarle la córnea que teníamos, hasta tanto nos llegaba una córnea fresca. Esta ha sido la experiencia mía, y la realidad es que he utilizado la queratoprótesis de Eckhart, he utilizado también tejido fresco, un ojo sí fue a la tisis y otro requirió incluso un nuevo injerto. Esto lo discutí en la Sociedad del Noreste de los Estados Unidos de Córnea, y Sader Hanush, con quien rotó Federico hace unos años, digamos, logramos acuerdo, y él me contó su experiencia, que vuelvo a repetírselas acá, es que durante el fellow de córnea en el Wilside, los corneólogos rotan 2 veces al mes por el servicio de cirugía vitorretinal. ¿Para qué? Para manejar trócares manejar sistemas de visualización para resolver la situación básica que se les puede presentar. De hecho, esto lo presenté, como estaba padeciendo un paciente con endoftalmitis en Capadocia en este meeting, y bueno, recibí la felicitación de Janusz. Y después Marcelo, en el libro que publicó junto al pakistaní y Carlos Mateo, que está como coautor, muy modestamente conté parte de la experiencia que uno tiene en esto. Así que bueno, en la ajetreada mañana de hoy sin Sergio Plan logramos hacer el Ateneo. ¿Alguna pregunta? Bueno, muchas gracias a todos.